Hello and welcome everyone. Today we will be discussing a very important case, that is severe traumatic brain injury. What needs to be done immediately in the initial hours in the ICU. Traumatic brain injury impacts 70 million people globally, with changing epidemiology due to the aging population, particularly in the high income countries. Patients with traumatic brain injury often have additional medical conditions that can complicate the management. Survivor of severe traumatic brain injury can suffer from significant deficits in motor, sensory, and cognitive functions, severely affecting their quality of life. Introduction of international treatment guidelines have reduced the acute mortality in traumatic brain injury, but outcomes and acute mortality rates have not shown further improvement over the last 2 decades. Traumatic brain injury can cause immediate death to cells and damage blood vessels, leading to hemorrhages. This primary injury is worsened by what is called secondary injury. This is due to systemic insults like hypoxia, hypotension, and coagulopathy. The primary goal of the pre-hospital management in severe traumatic brain injury is to minimize these secondary insults through early pathophysiological interventions. Upon arrival in the emergency, it is crucial to stabilize the vitals and consider multiple treatment options to manage a severe traumatic case. There is a need for further refinement in the acute management, especially in identifying and minimizing the secondary insults early on to reduce the acute mortality. So coming first to the pre-hospital management. The traumatic brain injury initial management should follow the ATLS guidelines, addressing the airway, breathing and circulation, and a rapid neurological examination. Intubation should be considered for patients with a GCS of less than 8, though the GCS threshold for intubation is a matter of debate. Major systemic injuries often require intubation in the pre-hospital setting. Minimize time to hospital, but stabilize the patient first in terms of the hypotension and hypoxia on site before you plan to transfer. The expertise of the paramedical or the emergency doctors can influence survival chances. However, the benefit of an on-scene physician is not yet conclusively proven to be beneficial. After stabilization, transferring a severe traumatic brain injury patient to definitive care promptly is important. Maintain a saturation of more than 90 and a systolic pressure of more than 100 to 110. Permissive hypotension should not be done in these cases due to the adverse outcomes. Spinal motion restriction is crucial. However, the benefit of a rigid neck collar is questionable, with alternatives like the cushion block or vacuum mattress being preferred. Always suspect spinal cord injury in severe traumatic brain injury and assess the GCS score, pupillary reactivity and focal neurological deficit, both at the scene and also upon arrival in the hospital. For patients with low GCS or signs of herniation, consider a temporary ICP reducing measure like hyperosmolar therapy or mild to moderate hyperventilation, but avoid too low PCO2s because this can lead to vasoconstriction. Early administration of tranexamic acid within the 3 hours post-injury is recommended for certain head injuries despite mixed evidence on its impact on mortality and disability. So, this was the management that we need to do in the ambulance or at the site. So, what we need to do once the patient has arrived in the emergency department. Upon arrival, the ATSL protocols had to be reassessed with emphasis on the airway management, maintaining a circulation with MAP of more than 80, spinal immobilization, securing a venous access, and placing both an arterial line and a urinary catheter. Airway management protocols are institution specific, but endotracheal intubation is mandatory for severe traumatic brain injury. Induction agents like propofol are used cautiously due to risk of causing systemic hypotension and impaired cerebral blood flow. Ketamine may be preferred in hypotensive severe traumatic brain injury patients for its lower risk of causing hypotension and potentially ICP reducing effects. Barbiturates can also cause hypertension and are not recommended for the intubation purposes. While intraparenchymal and intraventricular ICP monitoring is gold standard requiring surgical intervention, non-invasive techniques for estimating ICP like the optic nerve sheath diameter pupillometry, transcranial Doppler are emerging and may be used as triage tools in the emergency department. So once you have stabilized the patient, the vitals are maintained, the next thing that you must do is see whether the patient has a raised ICP. If the GCS is low, or if you find evidence of increased ICP on optic nerve sheath diameter, please ensure that you start therapies to reduce the intracranial pressure. So when signs of increased ICP or cerebral herniation become imminent, immediate action is necessary. Coagulation disorders should be corrected promptly. Head and body imaging via multi-slice CT scans, including the entire spine, are performed immediately after the stabilization. Based on CT findings, urgent surgical interventions such as mass lesion evacuation or primary decompressive craniectomy may be required. A CT angio is advised if there is a suspicion of traumatic cerebrovascular injury like skull-base fracture involving the carotid canal. ICP and cerebral perfusion pressure monitoring are essential either post-surgery or as a primary step. Extensive surgeries on the organs during the emergent phase should be minimized. Now, CPP, which is indicative of the cerebral blood flow, is maintained through optimizing the mean arterial pressure, which is done by fluids, inotropes, vasopressors, and decreasing the ICP, with strategies like sedation, CSF drainage, barbiturate coma, and decompressive craniectomy. Despite trials, no neuroprotective agent has been shown to be of benefit in severe traumatic brain injury. Hyperosmolar therapy with hypertonic saline or mannitol is used for ICP reduction, but the optimal agent and administration method and the timing are not yet very clear. Recent research, including the COBE RCT, suggests that continuous infusion of 20% hypertonic saline does not improve 6-month neurological outcomes in moderate to severe traumatic brain injury compared to standard care. There is an ongoing RCT in the UK, that is the sugar or salt trial, which has compared both boluses of hypertonic saline and mannitol for managing elevated ICP in neuro ICU settings. Current guidelines suggest osmotherapy should be interim measure for emergent ICP reduction, administered in bolus rather than as a continuous infusion. So, what are the steps to be taken to reduce ICP? The first step, keep the head in neutral position, avoid any extension in the neck, optimize the jugular vein effluent. Elevate the head at 15 to 30 degrees. Treat any elevation in temperature more than 38. Optimize pain relief and sedate the patient. Even if the GCS is low, you can still sedate the patient because the low GCS could be because of the cerebral edema. Normal or negative fluid balance is to be targeted. Osmotherapy is to be given with 3% normal saline or mannitol, that is 0.25 to 0.5 gram per kg of 20% solution over 10 to 15 minutes. Optimize the serum sodium to 145 to 150 millimoles per liter. High suspicion of seizure, consider continuous EEG monitoring. Increase analgesia and sedation if required. Increase serum sodium to 150 to 155 and consider hyperventilation with PCO2 of 30 to 35 millimeters of mercury if you see that there are features of herniation. Consider adding ketamine. Barbiturate coma can be done. Mild hypothermia can also be tried up to 34 to 35 degrees centigrade. And finally, if nothing seems to be working, the patient is still seems to be having a raised ICP, go for a decompressive hemicraniectomy. Now coming to the medical management regarding the red blood cell transfusion and erythropoietin. The optimal hemoglobin for transfusion is still debated. A recent RCT found that liberal transfusion of 9 resulted in less post-traumatic vasospasm, lower hospital mortality, and better neurological status at 6 months compared to a restrictive, that is 7 grams per deciliter. Despite these findings, current guidelines caution against liberal transfusion at a hemoglobin of 10. A meta-analysis showed that no significant difference in mortality between the restrictive and the liberal threshold. The evidence suggests that hemoglobin threshold of transfusion should be between 7 to 9. Erythropoietin has been studied as its potential neuroprotective effect with meta-analysis of 10 RCT involving 2,402 patients showed reduced mortality with erythropoietin. Despite this, due to erythropoietin's poor blood-brain barrier penetration and mixed efficacy in the RCTs, it is not currently recommended as a routine therapy in the severe traumatic brain injury. So for blood transfusion, you can target a hemoglobin of 7 to 9 and try to keep it higher side, that is around 9. If you think that the patient is having bleeding from other sites as well, so bleeding from those sites can reduce the hemoglobin to less than 7 if it continues. So if you are finding bleeding, then target a higher hemoglobin, or if you think the patient is totally stabilized, there is no bleeding from any other site, you can target a hemoglobin of 7. Now, correction of the impaired coagulation. This is very vital. Impaired coagulation is very significant and potentially a treatable secondary insult in severe traumatic brain injury, with an increasing proportion of patients affected due to the age and the medications they are on. Traumatic brain injury itself can induce a coagulopathy evident in 2/3 of the emergency patients, particularly those with a GCS of less than 8, a base excess of less than -6, hypothermia and hypotension. Correcting the low fibrinogen level is also very crucial. A platelet count below 100 is linked with higher mortality. Platelet dysfunction is common even without the use of platelet inhibitors. While platelet transfusion can reduce the hematoma expansion, its impact on overall outcome is unclear, and the risk of transfusion must be weighed against the benefit of transfusing. For severe traumatic brain injury patients requiring surgery, platelet transfusion, desmopressin and tranexamic acid are considered options. Studies indicate worse outcomes with warfarin compared to the direct oral anticoagulants in terms of mortality and hemorrhage expansion. Rapid reversal of warfarin-induced coagulopathy using PCC and vitamin K is essential, noting vitamin K's slow action and potential volume load. Issues with FFP in elderly patients should be considered. Due to the DOAC's short half-life and up to 80% of their therapeutic effect diminishing within 24 hours of the last dose, assuming normal renal function, inhibitor idarucizumab is administered for severe traumatic brain injury patient on dabigatran, and a modified recombinant inactive factor 10A is advised for those on apixaban and rivaroxaban. Now, though PCC is recommended for reversing the effects of factor 10A inhibitors in severe traumatic brain injury, the role of this is recently found superior to standard care in to the 10A inhibitor targeted therapies. Spontaneous intracerebral hemorrhage may be revisited for severe traumatic brain injury management. Now, steroids. Dexamethasone is proven to be ineffective in improving outcomes of severe traumatic brain injury and is linked to higher complication rates, mortality, and thus it should not be used for acute traumatic brain injury. Anti-seizure. There is no evidence supporting prophylactic use of these agents to prevent post-traumatic seizures. Phenytoin is recommended by recent guidelines to reduce the early post-traumatic seizure, although early PTS does not correlate with worse outcomes. Levetiracetam is an alternative to phenytoin. The ongoing MAST trial seeks to establish the best practice for using these agents in traumatic brain injury. The next is temperature management. Therapeutic hypothermia is aimed for neuroprotection and an ICP reduction and has been shown in several RCTs such as POLAR and UTHRM to be effective in lowering ICP. However, it does not improve or may even worsen patient outcomes, including increased mortality and poor functional outcomes. The current practice, supported by limited evidence, recommends managing and reducing significant temperature elevation rather than employing active hypothermia, which may be reserved for exploration in RCTs. Monitoring of the ICP is a fundamental aspect of acute brain injury and has been associated with reduced in-hospital and 2-week post-injury mortality. Advanced neuromonitoring techniques such as brain tissue oximetry measurement and microdialysis can complement ICP monitoring in treatment algorithms. Surgical interventions. Immediate surgical removal of mass lesions or decomprehensive craniectomy may be life-saving in early cases, particularly with epidural hematoma, acute subdural hematoma, and cortical contusions. ICP monitoring may begin at the time of initial surgery using intraparenchymal devices or external ventricular drains, the latter offering CSF drainage benefits. Primary decompression is considered for patients with significant brain swelling, poor neurological state with a large Frontotemporal decompression recommended to reduce mortality and improve neurological outcomes. Surgical evacuation is standard for EDH, especially when associated with skull fracture exceeding 30 centimeters cube or presenting with coma or anisocoria. Non-operative management can be considered for smaller hematomas in alert patients. Acute subdural require surgery if the thickness is more than 10 and a midline shift more than 5. Though smaller SDH may need surgery under specific conditions like GCS drop, herniation and dilated pupils or raised ICP. Center TBI study indicated varied treatment approach for acute subdural hematoma without clear evidence for superiority against an aggressive surgical approach. The rescue SDH trial showed similar outcomes with craniotomy and decompression in SDH patients with no benefit added with decompression. Cerebral contusion often progressed within the first 24 hours with immediate craniotomy indicated for significant mass effects. Decompression increases the risk of contusion expansion and is an alternative in case of diffuse swelling. Penetrating head injuries, especially gunshot, are associated with high mortality, intracerebral hemorrhage and raised ICP. Vascular injuries in these cases require thorough evacuation. Primary DC may be an option, although debridement of the necrotic brain tissue can be done. Cisternostomy, a newer surgical approach for traumatic brain injury, involves opening the basal cisterns to treat brain swelling but requires highly skilled neurosurgeons and is still under evaluation. Hinge craniotomy is another thing which is been done, which is a bridge between the medical therapy and traditional DC, but till now no RCTs have been done, so no recommendation can be done. Regarding the prognostication, it is a highly heterogeneous condition making outcomes difficult to predict. GCS classification is limited because it does not account for the underlying pathology. The most significant negative predictor is the severity of the injury, advanced age, absence of pupillary reaction and initial hypotension. Timing of the GCS assessment is vital due to potential rapid changes post-injury. Patients with persistent low GCS and bilateral fixed pupils from the scene have very low survival chances. Mortality rates with GCS of 3 and fixed pupil range from 90 to 95% with only 2 to 3% achieving good functional recovery. Patients with GCS of less than 8 post-resuscitation may face high mortality rates, but many survivors achieve favorable outcomes. There is currently no national guidelines recommending prognostic models for individual patient care. Prognostic models like IMPACT are mainly for research and not widely used in the clinical setting as of now. Decision making should be consider factors like underlying pathology, comorbidity and systemic injuries. For instance, if a patient of low GCS due to EDH is more likely to have favorable outcome after evacuation compared to someone with multiple contusions or diffuse injuries. Additional consideration include patient's comorbidity, systemic injury and the changing biological age, noting that many older adults may benefit from aggressive management and rehabilitation. The decision-making process regarding the palliative care of end-of-life decision, especially in geriatric population, is ethically complex with specific guidelines for managing TBI in older patients. Recent developments in the fragility index may help in prognostication. Maximizing functional independence while respecting the patient's wishes and quality of life is crucial in these cases. The availability of rehabilitation services can significantly impact the outcomes. Legal and cultural factors may influence the decision around prognostication, palliative care, and withdrawal of life treatment, highlighting the importance of understanding and respecting this variation in the care of severe traumatic brain injury. So, what are the take-home messages? The primary focus of acute management in the initial post-injury is very important to prevent the secondary insults. These include rapid correction of the coagulopathy, non-invasive identification of raised ICP, quick management of this raised ICP. Future clinical trials and observational studies are expected to provide more substantial evidence regarding the effective osmotherapy, the dosing, the timing, anti-epileptic agents, and temperature management. While awaiting the development of neuroprotective therapies, the emphasis remains on multimodal monitoring, managing secondary injuries during the crucial initial hours. A comprehensive, individualized approach is advocated for making treatment decisions, especially for older, severe traumatic brain injury cases, highlighting the importance of tailoring treatment to each patient's unique circumstances and needs. So finally, what are the targets that you must keep in your mind while treating these patients? Keep the ICP less than 20 to 22 millimeters of mercury, CPP of more than 60, systolic blood pressure more than 100, oxygen more than 75 millimeters of mercury, oxygen saturation more than 95, PCO2 35 to 40, temperature less than 38, blood glucose 90 to 180, and sodium 140 to 150. Thank you for your patience.